there is a great importance to talk about headache disorders because 95% of the general population has had at least one headache in their life. And when we look at the past year prevalence, it's usually going to be 1 in 2 people that will have the headache. So it's also a thing for GP consultations, say 1 in 10 people that need to consult a medical doctor will experience a headache. It's also 1 in 3 neurological referrals and 1 in 5 of all hospital admissions. It is among the top 10 causes of disability, especially for women. And also it's associated with a great burden cost, and a great personal burden for all the headache people, meaning that they have really diminished quality of life. Okay. To know how to differentiate specific headache disorders, one should be familiar with the International Classification of Headache Disorders, namely distinguish them among the very 2 different topics, a topic of primary headaches and topic of secondary headaches. To see how complex a migraine can be, we can just take a look at the very differences between a migraine phenotype. It can present like a migraine without aura, with aura. It can become a chronic migraine. It can have some brainstem auras that are typical, auras that are motoric, which means we can have hemiplegic migraine. And then we can have some really serious complications such as status migrainosus lasting for a long time and persistent aura without an infarction, migrainous infarction, and migraine aura triggered seizure, which we will talk about later. To start thinking of how to make a diagnosis, we usually, apart from just looking at the table presented just on the previous slide, we usually use some diagnostic tools that range from more general headache approaches to more migraine specific. But saying that, we know that migraine is still underdiagnosed, and a study here shows that about 44% of people with migraine are actually still underdiagnosed and of course undertreated. To navigate through this lecture, you will be watching at 5 different sections. So first we will talk about identifying migraine with specific symptoms and why they're important, why they will raise awareness of some kind of a secondary headache disorder. And then we will go briefly over the primary headaches, concentrating mostly on secondary headaches, raising awareness on the flag concept, and finally graduating with a clinical example. So what can we say about migraine? It's a recurrent headache disorder that is moderate to severe, characterized by throbbing and pulsating pain. Usually it's unilateral, and it's accompanied by some other associated symptoms such as nausea and or sensitivity to light and sound. The migraine features need to report to certain criteria in order for the diagnosis of migraine to be correctly established, which means that you need to have 5 of headaches that fulfill the following criteria, lasting for a period of 4 to 72 hours and fulfilling this associated symptoms that are listed right here, but you know all that. So migraine actually comes in 4 phases, and those phases are prodrome, aura, headache phase, and postdrome. So the most dramatic phase is the one with the headache where the pain reaches really severe heights. And usually we're talking about moderate to severe headaches ranging from between, shall we say, 6, 7 to 8, 9, or 10 on the VAS scale. But it's not the place where you will confuse migraine with some other headaches. Most oftenly, you will confuse it when you look at the symptoms arising during the prodrome period that can happen 3 hours to several days prior to the migraine headache, the aura period, which lasts for 5 to 60 minutes before the headache, or the postdrome period that actually spans over 1 to 2 days after the headache itself. So migraine is all that we talked about, but migraine can be a little bit atypical, and that's where the secondary headaches come in. So migraine can be not just unilateral, but bilateral, and it can also vary during a single headache. It can be mild, not moderate or severe. It can be continuous and can last longer than 72 hours or shorter than 4 hours. It may have no accompanying features at all. And you can have some features such as aura without a headache or have an interictal hypersensitivity. So maybe we can take a look of all the symptoms arising throughout the migraine. So migraine is more than just a headache. You're going to, as a migrainer, you're going to experience some motoric impediment, autonomic symptoms, somatosensory symptoms, special sensory symptoms, cognitive disturbances, and interictal sensitivity. Why is that important? Not to overdiagnose, because correct treatment is an imperative for any condition in medicine. So what should we do when migraine becomes a little bit different? Well, there is a possibility that the migraine patterns have changed despite the fact that migraine has been stable for a while. Maybe it's because you have become less responsive to the medication or something new has happened. What should you think of? You should be familiar with the concept of red flags. And that's how you can actually, by using a careful history, distinguish some other important conditions that are also existing. How can you distinguish migraine from other headaches? Well, I've come up with this acronym, which would say just RIP it, which means re-estimate the principal headache features, interrogate your patient for other symptoms, and perform the physical examination for sure. So when we think of that, why are we going to be mentioning primary headache disorders? Because they're much more common. They're so common that they're 98% present. But secondary headaches are so important because some of them may really be life-threatening. How does it look like in a pie chart? So all of those migrainous headaches, they are most likely a migraine in about 95% of cases. But the rest will comprise of lesions and structural causes of infective and inflammatory disorders and genetic and syndromic causes. So other conditions mimicking a migraine, we call them migraine mimics. So what are the most common migraine mimics? Here you can see that among primary headaches, there are only a few. But secondary headaches, there are many, many different types and causes. Most common are those of vascular origin, then of infectious and inflammatory origin, then of space-occupying lesions, CSF pressure, trauma, and then exposure to certain substances or some other kind of disorders. But migraine can sometimes look like something else. But in that case, we're talking about migraine being a chameleon. Since there are a variable number of symptoms showing up, we can think of epilepsy, stroke, neuropathy, reticulopathy, GI tract involvement, vestibular system involvement, cardiac involvement, something like a syncope, even multiple sclerosis or functional, i.e. psychiatric disorders. Why is it so confusing? Well, because sensory symptoms tend to push us toward either central or peripheral origin. And then there is this special transient global amnesia happening in migrainous patients, usually affecting middle-aged women and lasting for 2 to 24 hours, where there is retained identity, but memory is normal and all the investigations are normal. There you can think of other psychiatric disorders. Well, let's start from the most common ones, epileptic disorders, some other kind of vascular disorders, and psychiatric as well. The aura time is also most confusing, and most like it is occipital epilepsy. What is the main difference? The main difference is that migraine auras are usually quite simple, linear, and in black and white. Less often they're in color. In occipital epilepsy, you will have circular hallucinations, and usually they are colored. So maybe that's a bit of a tip on a distinguisher. So let's see, a primary headache has no underlying cause, but a secondary headache is the result of another condition causing traction on or inflammation of pain-sensitive structures. To see how important it is, let's see the complexity of all the systems involved and why is it so important to know? Well, it's important to know because secondary headaches have potentially dangerous causes that have good response to acute treatment, but also have specific treatments, so we should aim for that and save our patients' lives. Let's move on to primary headaches. The most common ones, most commonly confused with migraines, are actually trigeminal autonomic cephalalgias or attacks. Why? Because they're unilateral with ipsilateral cranial autonomic features. They also sometimes have a similar treatment response, and that's how they overlap with migraine. And of course, they have autonomic features as well as migraine, and also associated symptoms such as nausea, phono, and photophobia. Usually, we confuse migraine with a cluster headache, especially if we're talking about a chronic cluster patient and a chronic migraine patient. What is the greatest difference? Maybe that's a sort of a take-home message for you. Well, you should ask your patient during your headache, are you restless or do you need to remain still and silent for a while? And if their answer is, I'm really restless, then you should be thinking more of a cluster headache. And if they prefer to stay silent, then you should be thinking about chronic migraine. Then we have paroxysmal hemicrania or hemicrania continua that can mimic either episodic or chronic migraine. So what you should do is to think of pain-free intervals. And if they exist, then you should be in favor of a migraine. And also what you should do is test those headaches for indomethacin, because the response to them, if they're paroxysmal hemicrania and hemicrania continua, is practically 100%. Migraines do respond to indomethacin, but not as complete as those two do. To confuse Sanctin Suna is not that easy because they're less frequent and their duration of attacks is a lot shorter. And here we come to the next term. So it's not a secondary headache, but it's a migraine borderline. We will be mentioning 3 of those symptoms right here. This one is called cluster migraine or migraine cluster. It means that for some patients, they will have the presenting features of both migraine and clusters, but they will not meet the IHD3 criteria for either or both, which means that we think of them as being coexistent, thus coining the term cluster migraine or migraine cluster. A very important thing is to think of new daily persistent headache when a pattern of headache changes. Why? Because usually it's present in people with pre-existing history of migraine, but it's also something that resembles migraine because of throbbing pain, because of the presence of nausea, phono, and photophobia, lightheadedness, and aggravation by physical activity. However, the onset is clearly remembered, and it is also persistent. The last thing we will be mentioning is hypnic headache occurring during sleep and mimicking migraine by frequency, duration, and the severity. So let's move on to secondary headaches. When can we call a headache secondary? Well, when we have diagnosed a specific disorder and documented it by scientific methods. And then the headache has developed in temporal relationship to the onset of the presumed causative disorder. What will help us is that the headache will get significantly worsened if there is worsening of the presumed causative disorder, or significantly improved if there is improvement of the causative disorder. Lastly, it should not be better accounted for by another ICHD3 diagnosis. When we look at the list of all the secondary headaches, we see that a migraine, that they can all mimic a migraine. So why is it important? Well, there are about 118 causes of potential secondary headaches, and mimicking migraine for some of them is really life-threatening. What's most important, they request and require further neurological investigation. Which are most important? Let's take a look at the Spanish study performed in a Spanish ER in Valladolid Hospital, where the results were the following. So the most common headache appearing in the ER was the one attributed to vascular disorder, which is sort of natural. When you come to think of it, most of our ER cases are strokes or TIAs. Then the second one is migraine. The third one, headache attributed to infection. The fourth one, headache attributed to non-vascular intracranial disorder, and the others were more sporadic and occasional. So let's talk a little bit more about vascular secondary headaches. They consist of stroke or other vasculopathies. They also consist of something of a concept of thunderclap headache. What does it mean? A thunderclap headache means that the peak pain intensity happens in less than a minute. Some authors say in less than 5 minutes. However, it's really fast and it's really strong. So why is it confounding migraine? Because of the pain severity and quality of the pain location and duration. And what can help you distinguish it? Well, the neurological symptoms and sign and maybe changed or altered level of alertness. Is there some connection between TIAs and migraines? Well, yes, of course. It seems to be if somebody has a TIA, especially in the posterior circulation, lasting for less than an hour. And if you're a man, and if you have had it in the previous year, and it was a migraine without an aura, you are in 30% of chance of getting a migrainous headache. There are some other, maybe less common vascular secondary disorders, such as AVMs, that usually happen in the occipital region, thus sometimes inducing migraine-like headaches with visual auras. They're usually side-locked, which means unilateral, and they're usually atypical with also atypical associated signs. And of course, you should be aware there and look for neurological signals and signs. What can we say about aneurysms? Well, aneurysms are not that uncommon these days, and the most important ones are those that are saccular. Why? Because they have a compressive effect on the surrounding tissue. And if they are symptomatic, headache will present in up to 50% of patients. And what about vascular malformations? Well, this is a really important take-home message. So usually we're talking about cavernomas or angiomas or telangiectasias that can present with either migraine with or without an aura, usually with an aura. And depending on the level, if we're talking about upper level of the brainstem system, we'll be talking about an ipsilateral headache and a little bit lower, contralateral headache. And if we're talking about a little bit lower lesions, we'll be talking about an ipsilateral headache. Why is that important? Because it has helped scientists determine and prove that there is evidence for the involvement of brainstem in the initiation of migraine. We can also say of something about some other causes, such as cervical artery dissection. Those can be either happening in carotid arteries or vertebral arteries. Well, it seems so that headache is something that comes before neurological symptoms. It comes in closer temporal relationship before the symptoms if we're talking about posterior circulation. So there's just a time lag of only 15 hours, while if we're talking about anterior circulation or the carotid artery, there's a time lag of about 4 days. Pain is usually ipsilateral, and it's more of an aching characteristic. But if aura is present, you are expected to have a march of symptoms, first visual, then sensory, and then motoric. And that is particularly important, and it should raise awareness of a potential dissection in vertebral artery. You're in luck if some of your patients has a partial Horner system, because it will show up in 1/4 of all the people with carotid artery dissection. What's more, the dissection itself could just trigger another migraine attack. What can we say about cerebral venous thrombosis? Well, it's rather frequent and it's really migraine-like, and it is actually causing a mass effect in the head, and that's why that's why the pain starts. However, maybe you should think of it if Valsalva maneuver is really something that turns it on, or if sleep or lying down aggravates it, or if it started as a thunderclap headache, especially if the pain is worsening on straining. Then we can talk about reversible cerebral artery vasoconstriction, or RCVS, that could easily happen in postpartum period and most commonly in women. And of course, it's migraine-like, so it's most likely throbbing with associated symptoms. It's also, it can also be spurred by Valsalva maneuver, coughing, and exertion. However, it will commonly resolve in 1 to 3 months. What about temporal arteritis? Maybe that's a little bit easier because we're expecting it to happen over 50 years of age. It's more often happening in women. It's again very migraine-like. What about SAH? Well, headache may be the only symptom in about 1/3 of patients. It's usually bilateral. It can happen anywhere in the brain and it's gradually increasing. It's often associated with nausea and vomiting, but it can also, just like the dissection, be a trigger for migrainous aura. The headache with SAH, importantly, may also mimic migraine by improving with the administration of triptans. And then we have some encephalopathies that are of genetic origin, such as CADASIL, with white matter hyperintensitas, microbleeds. And what you should know that you should expect about 30% of all of your patients having a migraine. And actually, as a first presenting symptoms, it will happen in about 8 to 9 of your 10 patients. Well, here there's some information of CADASIL as well, but you should concentrate on MELAS because that's the second borderline syndrome, which means that it's a mitochondrial disease. It's of genetic origin, but it's coexistent with lactic acidosis and also migraine. And it's the second migraine borderline symptom that we will talk about today. Other vascular disorders, now leaving on from CNS disorders, are like hypertension. So which hypertension is very important? Well, if your blood pressure is over 180 over 120, then you can expect a bilateral and pulsating pain that is migraine mimic-like. Or you can have an anginal headache, which means it could be either unilateral or bilateral, again, with associated symptoms in a third of the patient. It could be brought on by exercise and relieved by rest. It could be accompanied by the usual cardiac symptoms such as chest pain, pain in the left arm, radiation of the pain to the mandible, or epigastric pain in 50% of the cases. But take a look at this. Cardiac cephalalgia is the only manifestation of cardiac angina in 27% of cases. So one should think of that as well. The second most common cause in the ER after migraine, or the third actually after migraine, we have infectious diseases. So usually we see people with isolated sphenoid sinuses that have some specific location determinants and also fever and some lab work and so on. But we could have what could be masked as a migraine is also a viral meningitis with severe throbbing bilateral headache. And of course, in that case, we're expecting a stiff neck, hopefully. It doesn't happen always, even if the meningitis is not viral, but bacterial. I have seen patients like that as well. There is a specific kind of meningitis. It's called recurrent benign meningitis or Muller-Reyes meningitis, which could be attributed to many different causes. Most oftenly, we're thinking of herpes virus, and it can occur without a fever. Thus, if you see all the symptoms of a migraine, you really might well think that it is one. And then we have a brain abscess that's really rare, but it's quite migraine-like, and sometimes it can evoke an aura as well, but it can, because of its duration, mimic status migrainosus, a very important thing to evade. Well, the last thing, or not the next thing, not the last thing, the next thing that we're going to be talking about are the neoplasms or mass lesions that occur inside the head. And usually the migraines are present in about 15% of the cases. They could present either as migraines with or without an aura. And we could be talking about colloid cysts, meningiomas, craniopharyngiomas, cerebral metastasized, brainstem or brain gliomas, and pituitary tumors. So pituitary tumors sometimes end up as pituitary hemorrhage, producing a migraine-like acute headache that actually the patient will have a normal neurological examination. The pituitary hemorrhage can be easily overlooked and underestimated because of the thickness of the slices. So maybe you should be aware of that. And also, you should be checking for the CSF and looking for gliocytosis. Then there are some less common causes that we can mention here. It's the Handel syndrome. caused by the activation of the immune system that is also presenting as a throbbing headache. And in 80% of the cases, there are some transient neurological deficits. They are usually unilateral, and most of the time presented on the left hemisphere brain, or the left brain hemisphere. But what's most important here is what we can find in the lumbar puncture. So there's an elevation of the opening pressure, and then we will have a lymphocytic pleocytosis and elevated protein. What's really important is that the patients will recover completely, shall we say, in about up to 3 months' time. But if you have a patient like that with a throbbing headache, but that patient is presenting with confusion and agitation, you should actually raise concern for something quite different and really important, and that's an NMDA receptor encephalitis. Again, look for the CSF signs. Next, we're going to be talking about high and low cerebrospinal fluid pressure disorders. So we have IIH, so intracranial hypertension. So it's daily increase, usually characterized by a daily increasing pulsating headache. And see, in most of those patients, there is usually a premorbid history of migraines. And sometimes, if that's the case, just the daily increasing headaches will make you think that what's happening is that now migraine has become a chronic version of itself. So maybe one should be aware and check with the eye doctor if there are any more signs of that, and maybe check for the CSF opening pressure. Then we have a hydrocephalus caused headache, which is usually presented as migraine-like visual aura with visual aura headaches. And in that case, usually we will have some transient visual scotomas. One of those issues is having a spontaneous intracranial hypertension, where in fact, we can also, again, have a migrainous headache, but gradually evolving. But you should pay attention to whether it's alleviated when the patient is lying down. Usually that headache is not always bilateral, and that makes it more difficult to diagnose as well. As for some other reasons, maybe we should just think of that, like acute carbon monoxide poisoning, hypothyroidism, again, throbbing headache. And then there is something like, maybe you can think of your patients that if they have a postprandial hypoglycemia, they will be predisposing to migraine. So go and check the blood sugar levels and maybe the HbA1c as well. Many medications can and will cause migrainous headache as well. So you may be thinking in many different other kind of conditions that are comorbidly active among our patients. Some other potential causes of migraines are glaucomas, inflammatory disorders such as SLE, medication overuse headache, that has actually been the third most frequent headache worldwide. And of course, we have the alcohol withdrawal headache and caffeine withdrawal headache that are not that dangerous for our people. Have you ever heard of the SMART syndrome? So it's a stroke-like migraine attack after radiation therapy. And who does it affect? Usually young people aged from 1 to 35. So far, there have been about 40 cases reported of those migraine-like headaches. And what's good about it is that it's a post-radiation reaction of the brain, lasting for about 3 months and afterwards completely resolving. How can you detect it? Well, you should do an MRI, and then you will see a thick unilateral gyrform cortex enhancement that should be involving typically in, shall we say, half a month to 1 month time. We don't know the pathophysiology of it, but we label it as a SMART syndrome. Also, very rare cause of migraine aura, where patients experience distortion in body images, so it's a little bit of a complex aura that we can see here, is the Alice in Wonderland syndrome. In about a little over 10% of cases, a migraine can be causing it. And most of the time, we're going to be thinking of an infection with an EBV virus. So what's important also to mention is that sometimes administering topiramate, which is something that we use for migraine prevention, can also cause this distortion in body language. However, it's completely benign and it will resolve itself by itself. I have browsed a literature a bit just to see if there's anything rare. So I found cerebral neurocysticercosis, which is the image that you can see on your right screen side, then neurobrucellosis, then optic neuritis, and then sickle cell disease. So it seems to me that many causes can really mimic a migraine disorder. What about pregnancy? Well, we do know that migraine occurrence during the first and second semester of pregnancy is usually how it is before the pregnancy itself. But in the third trimester, the pregnant women should be headache-free. However, if the headache occurs in the third trimester, you should be really aware. Usually it's due to homeostatic disturbances, vascular problems, or some newly occurring space-occupying lesions. So what you should think of is the red flags in pregnant women. And the acronym for it is pregnant HA, which means proteinuria, rapidly onsetting, elevated blood pressure or temperature, gestational age, yes, we said that, third trimester, present and concomitant neurological signs and symptoms, altered level of consciousness, no headache history or prior history of a secondary headache disorder, thrombocytopenia or thrombocytosis, high liver function tests or CRP, and agonizing severe pain. And the last one of our borderland syndromes is migralepsy. Migralepsy is an epilepsy that has been started during or within 1 hour of a migraine attack in a person who has migraine with aura. It's very difficult to diagnose, and it's been started by this case report of 19 patients, and it was published by Lennox and Lennox. And afterwards, this first publication has received some criticism because there was not a meaningful and unequivocal migraine epilepsy sequence. And some of those patients, namely 2/3, seem to have rather symptomatic and idiopathic occipital epilepsy with visual hallucinations. So no migraines at all. But there is a special connection between epilepsy and migraine. We do know that focal seizures can mimic migraine aura. We do know that migraine aura, especially visual one, can be confused with occipital seizures. We have seen the pictures of how auras and seizures look like in the beginning of this lecture. We know that occipital seizures are often followed by a migraine-like headache. So post-ictal headache usually occurs in about 50% of people. But we can also have something called hemicrania epileptica, which is an ipsilateral headache with migrainous features as an ictal manifestation of the epilepsy itself. It is labeled in the ICHD classification as migraine aura triggered seizure. You can find it there if you need it. So now that we know everything that can happen, we should just remind ourselves of the concept of red, orange, and green flags. When should we consider a migraine mimic? Initially, upon initial evaluation, when your patient has first showed up in your office saying, I have a headache. Then you should be thinking of excluding primary headache disorders first and then secondary headaches. When your treatment response in your patient is not as expected or getting worse, and when your patient tells you that there is more than one type of headache that's present. Why is it important? Well, because primary headaches actually do not pose too much of a danger, except from a stroke risk in migraine. But the secondary headaches can have, if unrecognized, a mortality as high as 50%. Once again, let's summarize this. So primary headache mimics are only several types. So it was easy to name them here. But secondary headache mimics any condition, and all conditions can actually produce migraine-like headaches. So when should you think of that? Well, after taking history and physical examination, because you're aware of the red flags concept, you should be thinking, are there any present? If so, then you should be thinking of secondary headache. And also, after seeing the primary headache disorder diary, perhaps see that there are any atypical features present. If so, again, think of the secondary headache. If not so, just follow this algorithm and choose one of the right diagnoses for primary headaches. What's really, really important is that you do not forget that the last criteria in the ICHD diagnosis is there is no better explanation for the symptoms that you see in your patients. So if there is no better explanation for a migraine, then it is a migraine. The best list to find, red flag list, actually consists, despite the fact that it's called Snoop 10 list, consists of 15 items. It was published in 2019, and it's very extensive, and it talks about systemic symptoms, neoplasms, neurological deficits, older age, pattern changes, positional headaches, precipitation by coughing and sneezing or exercise, the presence of papilledema, the presence of progressive headache and atypical presentations, pregnancy that we spoke of, painful eye with autonomic features, post-traumatic onset of headache, pathology of the immune system, specifically HIV, painkiller overuse, or any new drug at onset of a headache. So those are red flags. So what are orange flags? Orange flags cannot exist by themselves. They can, but they do not raise such a strong awareness. You need to have at least 2 orange flags, or concomitantly have an orange flag and a red flag to make it more important. Recently, in 2023, a group of authors decided to publish an article and propose a Snoop 12 list, adding 2 new more headaches to the original list. The first one will be consisting of post-COVID headaches, which are persistent and maladaptive and presenting as maladaptive neuroinflammation of CNS. And the second one, which makes sense because it could be the initial presentation and then you can think of COVID. But the second one, post-vaccination headaches with a late onset within a week to exposure of the possibility of CVSD, is what makes it really important. So increased coagulability and then secondary occurrence of cerebrovascular thrombosis. Finally, we have green flags. Why are they important? Well, because they actually are safe. So out of all the proposed items on the list, after really taking and evaluating carefully, scientifically, only 5 were selected to be the green flags. If your patient has items from that list, if your patient have items from this list, then you should be thinking of primary headaches. So what are those 5 items? The current headache has already been present during childhood. The patient has headache-free days. The headache occurs in temporal relationship with the menstrual cycle. There are close family members with the same headache phenotype, and the headaches occurred or stopped more than a week ago. So lastly, migraine is both a diagnosis of inclusion and exclusion. So let's graduate now. I'm going to be presenting to you this patient she is 42-year-old woman. She priorly had no headaches, and her initial symptom happened on August 6th of last year. She had speech impairment, she was paralytic, and she had pain in her left arm and had centrally affected her left facial nerve. She was hospitalized, but her neurologic deficits subsided about an hour from the start. However, a few hours from the beginning of neurological symptoms, she has developed a new headache, not known to her before. She had no other associated symptoms or signs. And it resolved. The headache not, but the neurological deficit was resolved. So what do we know about her? So from her previous history, we know that she has glaucoma, that she has divergent strabism, that she is being treated for seronegative spondylopathy, that she has had operation on her lumbar spine on several occasions, and because of it, she is suffering from neuropathic pain. Her functions are normal. She is not a smoker. She was a smoker at that point. She drinks 2 coffees daily and 2 liters of water per day, and she regularly exercises. So nobody in her family has headaches. What was she discharged with? Well, she had aspirin, a statin because she had high lipid levels, and then she had prednisone for her spondylopathy and pregabalin for her neuropathy from before, and sulfasalazine again for her spondylopathy, timolol eye drops for her glaucoma, and for her headache. Recently, she's been starting using a lot of analgesics, namely ibuprofen, paracetamol, and tramadol. While she was in hospital, what were the key findings? So the brain MSCT and the CTA of head and neck were quite normal, as was the carotid ultrasound. The transcranial Doppler showed slightly elevated mean blood flow values, and her ECG was normal. They also did an MRI a little bit later on her, showing some lesions that were explained as perinatal hypoxic ischemic lesions, and she actually had a little difficult birth because she was born as a twin. They performed an MRA and an MRV, and it was normal. And they performed a cardiac ultrasound showing an aneurysm of the interatrial septum with no apparent left to right communication. She not only did ECG, but Holter ECG, which was normal. We spoke of those lipids. So what did they do then? They did the bubble test that was positive. They tried to find some sort of immunological issue going on, so everything was negative. And they also sent her to perform a neuropsychological examination where she had higher intellectual verbal function, but mildly diminished executive functions. And it was quite impossible to distinguish whether it was really something coming from the brain itself or a psychological version. She was just discharged as a TIA in the end. That's why all of that was happening. She came to see me, it was September 11th. Why? Because ever since then, she has had a daily strong VAS 6 to 8 throbbing headache, not happening. She has changed, her quality of life has dropped so much. Where was it located? So dominantly occipital, bilateral, and in the cervical spine. Were there associated symptoms? Yes, phono and photophobia. She felt alleviation upon resting. One should take note that not lying down, just resting and being still. So she had no nausea and no autonomic symptoms. Her pain duration was obviously lasting more than 15 days per month. And she came to me for consultation. So I asked her I was not sure at this point what the correct diagnosis for her would be. We will talk about this a little bit later. So I asked her to differentiate and to do a cardiac echogram transesophageally to see if there is a left to right shunt finally, because the embolism signals would say that there are. So she didn't come to see me again for at least a month and a half. Why? Because she has had a second clinical event. She kept on having frequent, almost daily headaches. And on a month and a half after her first event, she felt a tingling in her left cheek and left arm with mild motoric deficit. She was again hospitalized. Initially, a CT was performed, and because it was normal, thrombolysis was performed with a complete symptom resolution. But remember, on the first occasion, she also had spontaneous symptom resolution within an hour. However, after this occasion, she had persistent paresis on her left hand, which ended up staying upon the discharge. She had no other associated symptoms or signs. So what did they do? They performed another brain MRI, and they did find the same lesions, but this neuroradiologist, said this time, is it maybe Catacil? But there's no involvement of anterior temporal lobes. Is it maybe demyelination? So they did additional testing. They did visual evoked potentials, which were normal, And they did cervical spine MRI, which only showed protrusions and no other demyelinations. They did the TEE, which means esophageal cardiac ultrasound, showing not only the aneurysm, but a BFO of 1.1 centimeters. The lab findings were inapparent this time. So what has changed? She stopped drinking coffee. She's not a smoker. She has no activities because her headache is so severe. And this time she was given Endoxin because of the PFO. They also suggested that she should check for thrombophilia, which was later found out to be negative. They sent her to do a clinical exon testing. We don't have results yet. And to do a consultation regarding a PFO occlusion. They also proposed to do a control MRI of 3 Tesla in 6 months. So what do you think is the likely diagnosis? What would be migrainous features would be a strong pain, VAS 6 to 8, throbbing pain, photo and photophobia, resting helps, localized pain, neck pain, aura. But what would be secondary features? Vascular events in temporal proximity, PFOs, MRI lesions, no prior headaches, no family history of headaches, residual deficit, NIH1 if you remember at discharge. And is there a better explanation? One can think of new daily persistent headache or reverse cerebrovascular constriction syndrome. We do know that migraine and stroke are interconnected at some point. In this case, this patient had a migraine with aura as a presenting. So there was an overlap. There could be an overlap with our CVS. Did she have stroke? No, we found no signs of it. She might have had a TIA. So we know from Lebedeva study that in stroke units, about 2% of our patients had a migraine aura, in fact, and not a stroke. And 1% of migraine auras were actually, in fact, treated with IV thrombolysis. Was it her case or not? We don't really know. So to clarify between migraines and TIA, one should be aware, and the take-home message here is that slow progression and positive phenomena will distinguish a TIA from an aura or an aura from TIA. Migrainous infarction she didn't have, so we're going to be skipping this one as well. So what is the connection between migraine and PFO? Well, it seems to be a dose response. The bigger it is, the more problems you have. What is the proposition? Well, aspirin. So what were the treatment options for this lady? Acute medication, should we? Well, we don't know because she is not in acute situation. She is at least having a subacute situation. NSAIDs, are they efficacious enough? Should we do the triptans? We don't know. Why? Because they're not good for vascular events. And also, should she take them daily when we know that we could cause an MOH? I don't think so. What should we do about PFO? Well, it's important to think about that, but it's not going to be helping her with the pain. What else can we do? Can we offer her acupuncture? Well, not bad, but it's not going to be helping. Well, what about Botox? Could be efficacious, but maybe a little bit complicated. And what should we do? Well, maybe we could give an occipital nerve block, and that's what we did. And guess what? The patient became headache-free. So without even knowing the correct diagnosis, there is still a big debate among us what actually happened here. She was actually pain-free, and she's quite happy and totally 100% responsive to that treatment. So your main take-home message is that headache history is crucial. When did your headache start? Is there a difference? How many headache types do you have? How often do you get a headache? How long does a headache episode last? Have you recently noticed any change in characteristics? What is the intensity, location, spreading? What associated symptoms did you get? Are there any aggravating or relieving factors? Is there a presence of neurological symptoms? What do you do when you have a headache? And what worries you about your headache? So now I believe you graduated from all this knowledge and you can safely relax, and thank you for your attention.